Hi, everyone. My name is Holly Fernandez Lynch. I'm the organizer of the Penn Research Ethics and Policy Series, along with Steve Jaffe. Today, we're going to hear from Dr. Nuala Meyer on research and rapidly evolving care during a pandemic. And as you may have heard Mary just mention, the REPS lectures continue to be recorded, and we're posting the videos on the Medical Ethics and Health Policy website just as soon as they're ready. I'm just going to make a couple of quick announcements before I introduce Dr. Meyer, especially since we've advertised this session a bit more widely. So we may have some new attendees who haven't joined us for a REPS session previously. First, the full REPS schedule for 2021 is now available. You can see all of our slated speakers on the screen here, and you can find out a bit more about the topics that the speakers will cover on our department's events page, which Mary can post in the chat. Note that we are accommodating Penn's longer winter break this year, so our January session will be on the second Monday rather than the first, and no one will be surprised that we plan to continue to be remote for the spring semester. Okay, oops, I don't know why I can't, there we go. Just another quick reminder that we are offering some online resources from our department. We have a series of faculty videos on ethics, policy, and COVID-19, which covers topics related to rationing, FDA regulation, and public health measures. And then we also have a series of short research ethics courses that are available for free continuing education credit. We have a brand new course on the ethics and regulation of social and behavioral research, which has just been posted. And then a late breaking announcement, which is this coming Friday, we'll be hosting another live webinar from 4 to 5 p.m. Eastern time on COVID and caring for children and the ethical issues related to that. This is another free event, but unlike REPS, please note that registration is required. There's a link at the bottom of the screen there that Mary will also put in the chat box. And we're planning one more webinar before the end of the year, likely to be held on December 18th, focused on the ethics of school closure and reopening. So we'll follow up with details on that event shortly. Just a quick thank you to our co-sponsors who make REPS possible, along with Mary Pham for her always excellent work behind the scenes. And now it is my pleasure to introduce today's speaker. Dr. Nuala Meyer is an associate professor of medicine here at the Perelman School of Medicine, where she directs the Center for Translational Lung Biology. A translational scientist, she and her team pivoted their ongoing sepsis cohort study to enroll patients hospitalized with COVID-19 into an observational molecular study that's yielding insights into the varied host immune response incited by SARS-CoV-2. She's also involved in several clinical trials for COVID-19 subjects. Dr. Meyer has been central to our institution's efforts to care for patients and to conduct high quality research and care during the pandemic, and that will be the focus of her lecture today. We're planning to make sure that there's plenty of time for questions. Dr. Meyer might pause at certain parts of the presentation and solicit questions, or we can also have questions toward the end. You're welcome to raise your hand, which you can do by going to the participants tab and clicking on raise hand at the bottom of the screen, or you can enter your questions into the chat and I'll compile and read them when the time is right. All right, with all of that housekeeping beside us, Dr. Meyer, let me turn things over to you. I will close my share here and you can take things over.
Great, and thank you so much for the invitation. Let's see. The screen is viewable?
Yes.
Okay, perfect. Let's see if I can advance. So I thought I'd start today by just describing a little bit of what it was like to be in the intensive care unit. I'm a pulmonary critical care physician, so ARDS is kind of our bread and butter, but kind of just give you a sense of what it felt like to be a clinician during that time and some of the early both policy issues that arose and ethical issues, and then how we got started with research. I thought I'd try to reflect a little bit on some of the policies that we enacted early and kind of maybe grade them as success or not a success, and would love your thoughts on that. And then close by just thinking about ongoing both ethical and policy challenges that the pandemic poses for us. I have just a few disclosures. Relevant to this talk, I am a site PI for the I Spy COVID platform trial, which is active right now. So as everyone's very, very aware, in December 2019, we started to hear reports of this novel coronavirus associated with cases of very severe pneumonia. That was pretty quickly identified as this SARS-CoV-2. And the early reports coming out of China really described about 20% of hospitalized patients being admitted to the ICU with ARDS that was frequently severe. And I'm showing you some images just from this past week or two when I was in the ICU, just to highlight these are afflicting patients who were otherwise relatively healthy. So the bottom chest x-ray is a woman, 63-year-old with moderately severe asthma, but really on no medicines except inhalers, and currently in our ICU, quite hypoxic, alternating between high flow nasal cannula and helmet CPAP ventilation. And above, a CAT scan, representative CAT scan from a 50-year-old with no past medical history, just to show you the really dramatic ground glass mixed with consolidation on these chest CTs. So very severe patients that often would require critical care for weeks, sometimes months. And of course, this is a form of acute respiratory distress syndrome, or ARDS. I'm showing you here kind of the Berlin definition for ARDS. So COVID meets all the definition here, that it's fairly abrupt onset, bilateral radiographic opacities, and frequently with severe hypoxemia. Pneumonia is the most common cause for ARDS, and viral pneumonia has really always been one of the hallmark causes for ARDS, with influenza probably being one of our other kind of pathognomonic ARDS patterns. But maybe worth highlighting that mortality for ARDS exceeds 30% at 60 days. That's if you take all categories combined. And severe ARDS has a 60-day mortality closer to 45%. So this, and we do not have any specific therapy for this, so really quite a challenge. Thinking back to January 2020, we had one of our large conferences kind of early in 2020, and actually had clinicians from Wuhan who came and presented, shared their experience, and really described this high rate of ARDS, frequently cardiomyopathy and shock, but it was really a fairly lung predominant condition. They had already noted the proclivity for patients who had kind of cardiovascular risk factors, hypertension, diabetes, and hyperlipidemia. And then Italy really quickly became the epicenter. And what was interesting about this is in the critical care world, the Italian intensivists are actually quite world renowned for being ARDS experts. And in a way, I think this was helpful, but I'll point out a couple ways maybe not so helpful. And this is what the information, kind of how it was disseminated. So through personal communications, we actually got, this was one of our, on the right-hand side, one of our early cheat sheets that kind of what to expect. We really hadn't seen this. In what ways did COVID seem similar to typical viral ARDS, and in what ways was it different? Some of this came through literally just an email from our Italian intensivist colleague, who is an anesthesiologist, Dr. Sereda. And I think a lot of us experience this, just unconventional peer-to-peer sharing. So it's the first time I've ever really considered getting any type of medical advice on Facebook, or sharing medical advice on Facebook, as well as looking to press reports as a way to really evaluate new data that was coming out. So just a very highly unusual time in so many ways. And here I'm showing you some of the early recommendations from Italy and from China, describing us to really encouraging us to prepare for the surge, to cancel elective procedures, to start taking stock of our ventilators and negative pressure rooms, and decide how to allocate those, to try to keep COVID and non-COVID patients and practitioners separate, to expect healthcare workers to get sick and to expect COVID to spread within the hospital. From Italy particularly, we had strong encouragement to intubate early. So this is to place patients on invasive mechanical ventilation and to avoid some of our supportive care like high flow nasal cannula and non-invasive ventilation out of fear that it might aerosolize the virus throughout the room and therefore infect more healthcare workers. And as part of that, again, trying to limit the spread, we actually changed some of our ventilator circuits to try to keep a dry circuit. And if we maybe just look at and try to grade some of those practices, I think some of them were just invaluable. So this peer-to-peer sharing allowed for very rapid dissemination of knowledge for a new condition. And I think absolutely China, Italy, and New York's experience really helped us to prepare. So we kind of had that 3 weeks of advanced prep time from the virus kind of starting to really ramp up in Washington state and then hit New York. And I think those few weeks of lead time really allowed at least Penn to really prepare. We interrupted elective surgeries, tried to kind of depopulate the surgical ICUs, which opened up many more ICU beds and providers. We took stock of our ventilators. We obtained additional supplies. So I'm showing you here a picture of a man in a helmet ventilator. This is something that's pretty widely used, definitely in Italy and in other places of Europe, but we had never used it here. And it's basically a CPAP with high oxygen, but delivered through a helmet interface. This is actually a soft plastic, so it could be almost like a Ziploc bag when not inflated, but when pressurized looks like this scuba helmet. And we continue to use that now. And early on, we really did designate COVID and non-COVID locations in the hospital and tried to keep the staff caring for COVID only with COVID, and conversely, non-COVID only with non-COVID. And I think this was really remarkably helpful in the early days where there was tremendous uncertainty about whether personal protective equipment was going to work and whether healthcare workers would be falling ill, even while being kind of properly protected. But to focus on that a little bit more, you know, maybe there was too much emphasis on this anticipation of healthcare workers falling ill. So we changed all our staffing with multiple layers of backup. I think all of us are familiar with our daily symptom check, but doing that every day and saying, are you okay to take care of COVID patients? Are you in quarantine? Are you sick? Do you want to talk with anyone about your mental health? Every day was quite exhausting, really. So we also made a lot of staffing decisions where we had physicians self-identify if they did or did not want to be included in the pool for COVID providers. And since we had so many additional ICUs active at this time, this meant we had a smaller pool of critical care physicians doing more work. So many of us were on service about every third week during this time, and some with a very heavy nighttime presence. So the good things here, we definitely maintained our staff. We were constantly updating recommendations for personal protective equipment and how to respond to codes, how many providers could go into the room, who had to stay outside, what did you wear as you did all these things. And I think it was certainly a success in that staff illness was quite low once we started universal masking. I think there have been some outbreaks which typically preceded the universal masking. But again, I can't stress enough that what an exhausting time that was, and many of you probably experienced it in your own lives. And that really, I think this anxiety about the healthcare worker falling ill strongly influenced care and continues to do so. So I think from an ethical standpoint, there are certainly some necessary trade-offs between expediency, such as responding to an emergency, and safety. So if no one was standing in personal protective equipment and a patient becomes disconnected from the ventilator or has a cardiac arrest, typically we were encouraged to stop and quickly don our protective gear and then rush in, and to accept that delay, which is quite a change from our typical training that, you know, time is heart tissue and time is brain, and get into that emergency as quickly as possible. We had fewer staff in the rooms, and we continue to try to have fewer staff in the room for all emergencies in the hospital at this time, whether we believe it's COVID or not. And it really put all the personal protective equipment was difficult for our patients. So some of you may have listened to one of my colleagues, an obstetrician gynecologist, who described his long stay in our ICU and described both kind of struggling with delirium, but then everyone he saw seemed to be in a spacesuit, and trying to make sense of that. I also think we inadvertently started to tolerate what we might otherwise consider substandard care. So things like examining a patient through a proxy, saying that, well, the nurse is already in personal protective gear, so she can stay in the room longer and do my neurologic exam or do my volume assessment. That it's okay to have different thresholds for certain tests, that a COVID patient in whom we'd like maybe vascular Dopplers or an MRI or an echo, that they need to meet some higher threshold or go through some additional negative testing before providers are allowed to order a test. And in some cases, certain tests are just not available for COVID patients. And those decisions haven't really been subject, I think they've been subject to divisional discussion, but as the provider in the ICU, we struggle with that decision. So it seems not equitable to, in my cancer patient, I can have a brain MRI for the asking, but not in my COVID patient. Some of the other decisions, so we were really encouraged to intubate early. As soon as the patient got to 40 or 50% oxygen, intubate. And this is an area where I think we got it wrong, and we probably intubated too early and failed to use our whole armamentarium of oxygen support. I think now that we've seen more of the variability in COVID, we know that there are some patients who are what we call a happy hypoxia phenotype, who seem to not have much respiratory distress, yet be quite hypoxic. And if their work of breathing is low, some of these patients do really well with a prolonged support with high oxygen that's non-invasive. We weren't using it early because we were worried again about that transmission to kind of other workers in the healthcare setting. So we've really changed that. And then certainly something I think we definitely got wrong was this recommendation to modify our ventilator circuits. I know this is a bit detailed, but we kind of regressed, took out the heated humidity that is typical of most ventilator circuits, to keep a dry circuit, and this was thought to maybe lower the aerosolization risk for ventilated patients. And what we observed is sometimes we had these just absolute concretions in the endotracheal tube, causing airflow obstruction on top of, so superimposing an obstructive lung condition on top of a restrictive one. And so this led to many reintubations and airway emergencies. So we recognized this quickly and modified it by within the first month. But you know, I think we all regret that we ever made that change. Therapy was also what I would really describe as a bit of like the Wild West. So we were getting all kinds of recommendations from our president as well as other people to try different things. It was regrettable that, you know, we've come to learn that hydroxychloroquine, also known as Plaquenil, actually inactivates remdesivir. So here is hydroxychloroquine by itself does not help nor harm, but it may have harmed in that remdesivir, which is a more effective antiviral therapy, is inactivated by hydroxychloroquine for often weeks. So that very rapid adoption, I think we were all feeling like doing something was better than doing nothing. And in some cases, that was probably an incorrect calculus. And steroids was also kind of rapid flux, we were told. Yes from China, no from Italy, no from infectious disease, until the English came out and showed that it was reducing mortality, at least in the sickest patients. And just to give you a sense for, I tried to kind of color code what it's been like maybe at Penn Medicine. So our first case hit the ICU in early March, but then we really had several weeks with no additional cases. And then in the last week of March, we kind of had 3 in the ICU, then 6 in the ICU, then quickly we're opening 3 different ICUs to care for all of our patients. So we were really in our red zone in April into May. But then had a fairly quiet summer that is now ramping up again. Just to overlay what research was like during that time. So we started with observational research very early, as well as a few interventional trials. The ACT trial is an NIAID platform trial that was the trial that helped show remdesivir's benefit. Several trials on hydroxychloroquine started again early in the spring. Penn's homegrown convalescent plasma trials started here in late spring. We had a trial for acutely ill ARDS patients. And then more and more throughout the summer, we've had several trials looking at various levels of hospitalized patients, either from asymptomatic to requiring oxygen to ICU level, that all remain active now. Vaccine trials also started over the summer and have progressed quickly into phase 3, and we all know that they are essentially complete now and being evaluated. And unfortunately, here we are now in November and December with a rapidly growing census. So as of today, HUP census is about 90 patients plus 5 to 7 in the emergency room. We have 3 ICUs open. I was on this weekend and we were limited to, I think, 4 ICU beds remaining in the hospital, all of them in surgical units. And Presbyterian has about 60 inpatients. So again, back essentially to where we were in April and May. So I thought I'd highlight a few of the challenges, both logistical and some of the policies that just required major changes. So one that I didn't even think about until we went to enroll our first patient into our observational trial is just, how do we actually conduct this consent? These are sick patients. They're not always able to talk on the phone, or they may not hear you through their helmet or CPAP mask. And at least early on, describing to a family member that their loved one has tested positive for this novel virus was so alarming that each conversation took about an hour, and we really didn't see a way for a non-clinician to have that conversation. So these tended to be physician consents, even for observational research, with a lot of explanation. Even when you're speaking with the patient, this is me in PPE, so you can kind of get the sense for it. This is a challenging environment. Communication is difficult through all of these layers. Alternatively, we could use technology to solve the problem and use DocuSign, which definitely is a helpful technology, but I would say it's very helpful for you and me sitting in our office. It's very challenging for a patient in the ICU looking at their cell phone and trying to type. So this is not always a practical solution for an inpatient. Paper is practical, but what do you do with it? So it has to stay in the room or else somehow be decontaminated. What we do for some of our studies is place the signed consent folded so that signatures are visible into a plastic bag, sterilize that, put it in another bag, put that bag in the UV box and irradiate it. But these are, challenges we just hadn't really thought of before the pandemic. Though I will highlight that sometimes it can be really rewarding. I was trying to show you here, this was a note left for me as a patient was consenting saying, "Thank you all, you've been so amazing and taking care of all of us, can't wait to help any way possible." So sometimes patients really felt grateful to be able to participate. And this, again, was just observational research. I think it also highlighted some remarkable collaborations here at Penn between many different players, and the speed with which some of these collaborations got off the ground was really quite remarkable. Additional challenges: who should be in the hospital to do this research? So are all research personnel or any research personnel essential to the point that they should be allowed to take the bus or public transportation? How do we then handle the biospecimens? So this was one of our research team, Ariel, kind of picking up specimens to transport to the lab. She has them sealed in 2 bags, and those bags are in a biosafety box. And then they're brought to a lab to BSL-2 enhanced. But this is great if we know the patient is COVID. What if we don't know that the patient's COVID and the patient tests negative as they enter the hospital, but positive 2 days later, which has definitely happened? What do we do about everyone who handled their blood 2 days prior thinking they were non-COVID? So I think we're going to have to rethink our universal precautions. And if we think there's additional barriers that need to be put in place, just like we have changed for other infectious diseases, I think we're going to need new universal precautions. From a research standpoint, we were also concerned, what if our viral inactivation methods end up kind of inactivating your data? So what if they change protein levels or change some proteins more than others? We haven't yet been able to test that fully. And then kind of the thought on, so if we can accept that COVID-related research is essential because we need to learn what to do for this virus, what about all the labs we shut down that were not COVID-related? And is there any less urgency to understand cancer mechanisms in the midst of a COVID pandemic than outside of a pandemic? So the people struggling with that cancer would say they really need their mechanisms to be figured out and new therapies to be found and tested. So I think there were a lot of, so we shut down labs for about 4 months, and many people lost cell lines, animals, research, lost the opportunity to kind of submit for grants. So I think we're still trying to understand the impact of that shutdown with really good intentions. But again, somebody who has acute leukemia doesn't feel their acute leukemia is less acute because it's happening during COVID. And then turning to interventional research. So 4,000 studies in a disease that is not a year old is just remarkable. You know, how do we think about all these trials? So what is the best way? Several of us kind of serve on Penn's clinical trials committee that's meant to try to increase opportunities for participation to our patients in an equitable and just way. But how do we prioritize amongst different studies that maybe are targeting the exact same population? Should it be what's the best option for our patients? That sounds great, but who decides that? Who knows what's best before we test these therapies? There was a little bit of a first come, first serve. So those studies that were organized early got in the door, and then are we committed to them because we did 2 months ago, or has the science moved on and those are no longer our top priority? And how do you tell a trial that's ramped up to back off and let another trial enroll first? Should we look at kind of homegrown studies compared to multi-center studies? Should we look at the funding for the study? Should we think about the one that's most likely to get an answer. But again, how do we know that ahead of time? Can we think of what's impactful to the investigator or to the institution? And you could think of many equally compelling reasons that a study may be worthwhile. So we definitely have experienced a little bit of this with concerns that the same patients might be eligible for multiple studies. And is it just to try to prioritize amongst those different studies to say, we think this is the best study for you? Do we tell them that they're eligible for the other two that we're not bringing first? How do we balance kind of pharma studies that will pay really well versus maybe NIH studies that don't pay well but are large and multi-center and maybe likely to get an answer? So these are several of the things we continue to grapple with, I think. Penn's solution has been to have a committee with clinicians, scientists, ethicists, and IRB representation. But I would say we're not necessarily better than anyone else at trying to decide which trial is the most likely to get the answer, what's the best therapy. In addition, then there's a daily call that reviews all the newly admitted patients. And what's great is I think we have a very collegial approach where we try to be fair in distributing patients, but also look at aspects of each patient's case. And maybe if it's earlier in their symptom, maybe they're better for one study than another. We're pretty familiar with each other's studies at this point. And we do try to acknowledge, when presenting one study, acknowledge the other studies that the patient is eligible for, and just ask the patient or their proxy, what would they like to hear about? But it continues to be difficult, and I continue to be concerned that, it's a different process to consent someone in person versus over the phone. And are we disadvantaging people who English is not their first language, who maybe are more frail, don't seem as robust, and kind of being admitted at Hub versus Presbyterian versus Pennsylvania Hospital may absolutely dictate which studies can actually physically get to you to perform an in-person consent. Some of the questions we've come across: how many trials could be active at one time for a given patient? And is it ethical to enroll in more than one? So things we've heard is when patients know that they're eligible for several. So they say, okay, sure, I'll do that study, but can I also get the convalescent plasma, which is another randomized trial, and of course would like to be in only one study at a time. Or, okay, I understand, I'd like to do that platform trial that has a control arm that compared to just backbone therapy. And if I get backbone, I would also like to enroll in that second study. So then it's not really backbone. So this is real life. And I think we try to approach these from a patient-centered view, letting the patient or advocate choose what is their best option. But it can be difficult while plasma remains an investigational therapy. In addition, we have a changing standard of care. So new data keeps emerging. And a dilemma we've had recently is that there is a request to do a new trial comparing baricitinib, a JAK2 inhibitor, compared to dexamethasone in pretty ill patients, hospitalized patients on oxygen. I'll remind you that the recovery trial, which was very large, pragmatic, open label trial, but randomized, has identified a small but real mortality benefit in patients on oxygen. That benefit is magnified in the sickest patients, those who are mechanically ventilated. And among oxygen, this trial was pragmatic, so we don't know who was on just nasal cannula oxygen or who was on high flow. So is it ethical to have now a new trial with less less robust data, maybe a great mortality benefit in the high flow nasal population, but based on very few observations, is it ethical to withhold dexamethasone in them? What do we do with convalescent plasma when the FDA issues an emergency use authorization in the midst of us testing that as a randomized trial? So these have been some of the challenges. And maybe I'll, if there are questions about the research, should we stop there? I had a couple other policy things, maybe just 4 other slides to get through.
Yeah, why don't we pause here and give people the opportunity, since you've presented lots of questions that you've struggled with. I think it would be a good opportunity. Now, as a reminder, you're welcome to post questions in the chat or to raise your hand and I can call on you. In the meantime, Nuala, maybe you could talk a little bit more about this approach to patient choice to trials. So, my understanding of what you've described is that there's a committee that has prioritized certain trials to avoid competition for the same eligible patient populations. Now, you might have said, okay, these 3 trials are the ones that we're going to allow to proceed, to recruitment, but you have some mechanism of presenting one of the 3 first to eligible populations. And so is that being done just kind of randomized days? Like if you're admitted on a Tuesday, then you get offered trial A first, or maybe you could just talk us through that process a little bit more and some of the challenges that might come up on the patient choice model.
Right, so what we do is review, we kind of have pre-screened the new admissions of the day. I think each study is kind of screening all the time. So, but then we also have kind of a master list of the new patients' admissions with their objective data, this much oxygen, kind of these exclusion criteria. Are they in the ICU? Are they not? Are they already enrolled in an interventional trial, which for most trials would exclude you from participating in another randomized trial? And then a morning call with about 5 to 7 people on it, most of them representing a trial, but also our kind of very heroic ID physicians who are there to approve the remdesivir, which is still a bit of an investigational agent, listen in and can help be, I think, another just kind of fair advocate. And so if we have a patient who seems eligible for all 3 kind of cyclosporin trial, which we think cyclosporin is maybe most helpful for a more prolonged illness, not in the first couple of days of symptoms, but maybe at day 10 plus, but their eligibility starts at a week plus. A fenofibrate trial, which is really trying to target patients in the very first several days of therapy, of symptoms out to a week. And then a convalescent plasma trial, which is not limited in terms of time since symptoms, but has to be anchored around a positive PCR test. And the infectious disease community thinks it's probably most helpful on the early side again. So we often will just, and then I'm there to say, I think this patient actually looks like they're headed for the ICU. I know they're only on 6 liters now, but they're breathing 30 times a minute and they're 91% saturated. I'm pretty sure they're going to go to high flow next, which would make a patient ineligible for several of those trials and now eligible for a slightly different set of trials, which might be plasma and the I-SPY trial. So I think we try to at least say out loud the reasons for thinking that a patient may be better for one versus another. And as happened on this morning's call, when a patient really seems equally good for one versus another, somewhat at random, we say, okay, why doesn't trial A approach patient X and trial B approach patient Y? And that way they're each the first to present to one of those patients on one day. Thinking that way we can kind of spread the workload amongst different trials, whereas a Monday versus Tuesday approach might mean too much to do, and then some patients wouldn't be approached at all.
But regardless of what trial is offered to them first, they're notified of others that they're potentially eligible for.
Right. And so if a patient says, no, I'm not interested in that convalescent plasma, the next question is, okay, absolutely, we understand. Would you like to hear about any other trials that you're interested in? Or do you prefer no investigational medicine?
Oh, that's interesting, right? So that might mean that if they say yes to the first trial that they're offered, then they wouldn't be told about the others?
Potentially not. So again, I think we only know the conversations that we're in.
Right.
So my lane tends to be plasma versus I-SPY. So I do have patients sometimes bring up the plasma on their own, and our team does acknowledge plasma. Again, with the timing difference, like I think our trial is again focused a little more on later immune response. But we do, and sometimes the transplant patients in whom we're worried may not have a normal immune response, even if their timing might better fit I-SPY, we recommend them for plasma.
Okay, great. I have a couple of questions that have been posted to me in the chat. So let me read two of them together. One is just a logistical concern, which is you've articulated just an intensive burden for clinicians in terms of patient care. So how is it that clinicians have the time to care for patients as well as consent them for these studies if the consent process takes such a long time? And then the other question you had kind of touched upon previously, which is that some non-COVID research has been paused. And so how have those decisions been made in terms of which to allow to proceed and which to pause?
Great question. So for the first one, it's generally not the clinician who's doing the consenting for research for just the struggle that you described. The clinician needs to be focused on clinical care. Typically, the clinician might have a team member reach out to trials and say, can you tell us which trials they're eligible for? And I do find it's helpful for our colleagues to know our trials. So if we're enrolling a patient, we always try to communicate with the team what is the motivation of the trial, kind of what should we be looking out for. But we try to unburden the bedside providers from doing that. I think it's helpful for the providers to know about the trial so that if the patient asks, like, is this crazy? Should I do this? Which is not uncommon, that the providers can have at least some semblance of, I've heard about it before. But we don't expect them to be doing this consenting on top of their own work. That's the trial team's job. For the second question, how were decisions made? So I think there was a very careful consideration across the university, but at the high level. So I think IRB leadership and vice provost for research and vice dean for research. I'm probably not saying everyone's titles appropriately. I think that was where the decision making was for different levels of clinical trials that could proceed. Clinical trials that were deemed likely to have a direct patient benefit, so an interventional trial for acute leukemia, let's say, those were allowed to continue. Observational research on leukemia probably stopped for several months. But if you were eligible for CAR therapy and there was a team ready to give you CAR therapy, you could get CAR therapy even during the pandemic. I'm not sure if that happened, but I know those trials were not suspended. The mechanistic research and observational research was suspended. The labs were closed. So if it was not COVID related in general, that was closed for 4 months at the vice provost and dean level decision. And then there was a staged reopening of clinical research, again, with the level of likely to benefit the patients first. They remained open or were the first to reopen. Then active funded trials were the next level to open, sometimes with modifications that anything that could be done remotely should be done remotely. If you could modify your your study procedure slightly to allow patients to do things at home instead of coming in for visits, and monitoring. So study monitors, do they really need to be in the hospital, or could they be doing that remotely? So in general, all research is back open at this point and has been since, I want to say, August. Even more pilot studies and observational studies are open.
Great. Do you feel like you can take 2 more questions, or do you want to move on to the rest of your slides?
Sure. Why don't we do 2 more questions?
Okay. All right. So Steve Jaffe has a question. Steve, I don't know if you can unmute yourself. There we go. Great.
You should be able to see me. Hey, Noah, thank you so much for giving this talk. And, you and I spent a lot of time on committee calls together, and, so thank you for what you did for the patients as well as for the institution, because really, like, Penn Medicine could not have done this without you. My question is, sitting on the committees, the clinical trials committees, I think the committee probably said no to more trials than it said yes to in terms of this issue of prioritization. And I wonder if you could speak to what were some of the things, you hinted at this in your comments earlier, but what were some of the things that led the committee to say, no, we're not even going to allow this trial to move forward at Penn Medicine, even though there's a willing investigator and maybe a funding source and all of that, but it's not high enough priority to even be done?
Yeah, I think we deprioritized phase 2 pharmacy sponsored, industry sponsored, with the thought that there may be 20 trials. And I think when you see that there are 4,000, really that should be, there are hundreds of trials where people are saying, I like my agent and I want to test it in 20 patients. And we know that 20 patients will not be enough to really appropriately identify what the signal is. It's probably not enough to really understand safety. And it's just so far removed from being able to rapidly influence patient care that those were deprioritized. The committee tended to favor, I think, equally. One were kind of very strong mechanism guided and Penn homegrown studies that someone has a lifelong career looking at this molecule, and this molecule has a really strong rationale for COVID. Those were the only phase 2 type studies that I think were really supported. And alternatively, it was phase 2 to 3 large multi-center, likely to move efficiently and get an answer, either this is helpful or it's not helpful, and move on, so that we don't look back a couple of years from now and say, we did lots of 20 to 50 subject studies and have nothing to show for it, but nothing looks like a dramatically large effect and nothing is totally excluded. I think the hydroxychloroquine is probably not our best example as a medical community of what we accomplished, but at least we are confident in the effect or lack of effect of it, right? Because so many studies were done on hydroxychloroquine. And then I think we say no to a lot of industry, very like labor intensive or device intensive. So there were some proposals to move COVID positive patients all across the hospital to get a very experimental procedure that might be labor intensive and tie up a lot of nurses in PPE, but only for 10 patients. That was also not prioritized highly.
I think that actually that has resolved the other question, which was focused on how do you decide what trials are most likely to get the answer. But there is one part that maybe remains unanswered, which is how can decisions about effective research be made at an institutional level without more national or international level guidance?
Oof, great question. I don't think I have the answer for that. I do think even at our institutional level, many of the participants were also serving on national committees. So certainly we have infectious disease membership on the CDC guideline committee. So I think it was helpful to know their conversations. And we have 2 members who are part of the ACT platform trial. So they're in a national conversation on the critical care side, I'm on the iSpy platform, which again is a bit of a national conversation, but potentially in conflict because this trial is trying to advance its own agenda. I think that's a great question.
Okay, I think we better let you proceed since we only have about 6 minutes left.
Sure. So just a couple policies that I think at least I still struggle with, and I think my colleagues do as well. And maybe this will just kind of stimulate the conversation for the last few minutes. So is it the same ethical calculus now as it was in the spring? Should we still tolerate limitation of services when we have not seen healthcare workers by and large fall ill when appropriately using PPE? I still struggle with this. I still can't order an echo in the same way for my COVID patients as not. And it seems strange that we have some tests that are allowed and others that are not. With providers, does this not have a bit of undertones of the early HIV epidemic? Like, we all care for HIV patients now. We all care for influenza patients. Will there be a time where COVID is just part of, we know the infectious precautions to take? Many of you may be aware of this editorial by one of my colleagues at University of Michigan, Jack Awashina, the transfer policy. So we don't transfer COVID patients to HUP or Penn Presbyterian as often as, say, someone needing advanced hepatic failure care or advanced cancer care. And just to highlight from this article, patients at some community hospitals were 3 times more likely to die as patients at medical centers in the wealthiest parts of the city. That was New York City during its tremendous surge. So even if the request is not necessarily for some device or care that could not be provided at the community, might there still be a benefit to bring them to the university where Penn's outcomes were really good? So I think we struggle with that ethically. The visitation policy. This has evolved, and so as I was thinking about this, the visitation has really changed even in the last week. But at the height and now again, we have pretty strict restrictions for any visitation. And at one point, your visitation allowance was different if you had end-of-life care with comfort measures only, kind of a palliative approach, compared to restorative goals, a full code approach. That it was 2 people a day versus 1 person a day, and one extended family, all the immediate family could be there for at least a few hours. That felt really inequitable. And of course, the visitation policy is really challenging to establish rapport. I think it's really challenging to engender trust through a screen, and continues to be really, really tough on patients and providers. What do we do about family members who've recovered from COVID and say, well, I already had it, or I have a PAPR, or I have a negative test right here. So all of these, I think we're trying to be just and fair and apply the same principles. And I think it's been good that they have closed the gap now between the palliative measures and restorative measures. Staffing policy. So in a surge, I think we tolerate a lot of changes, but we've kind of surged with a different staff model for some of our surge ICUs as not. That continues to feel maybe not right. And then the vaccine policy. So I think everyone agrees with CDC's priority. We just recognize that there's a lot of gray here in kind of frontline healthcare workers. So I think we all agree emergency situations, people who work with COVID patients of unknown status. And so Penn's implementation will focus on emergency, trauma, L&D, COVID testing areas. Notice that the inpatient COVID services are not on this list, which is evidence-based. We are not falling ill. At the same time, I've had some colleagues say, that just shows the institution's priorities. They're not interested in protecting us until they protect our ECMO team or our transplant team. So a couple of the things that I came across.
All right. Well, I've really learned a ton from listening to you, and thank you, and echo Steve's thanks for all you've done through these past several intense months. I think we might have time for one question, if anybody has one. Okay. All right, well, I think then we will close. I apologize for the Zoom bombing earlier. That is the first time that's ever happened to us. And you handled it beautifully, and thanks to Mary for handling that as well. And we will post the video of this as soon as it's available. Thank you again, Nuala, for a really fantastic presentation.
Okay, thanks so much for having me.